Hello, dear students. Today we will discuss about ischemic heart disease, different types of ischemic heart disease, and what are the different pharmacological measures by which this can be controlled. Okay. First and foremost, what is ischemic heart disease? As it is shown in the slide, that there is a ischemia, and these ischemia leads to, first of all, you should all know what is ischemia. Ischemia means the symptoms because of the decreased blood supply to the heart. Okay, and if we want to expand it further, because ischemia is a relative term. Now why I am using this relative term? Because many a times the blood supply is adequate with the routine demand, but it is not adequate for the extra work or exertion. And that's why, to explain in a more proper way, if there is an imbalance between the oxygen supply and the demand, then there is a development of ischemia and symptoms because of it. And ischemic heart disease means there is an imbalance in the oxygen supply and the demand of the heart, and the heart will complain in terms of chest pain, and the complaint of the heart in terms of chest pain is known as an angina. Okay, so angina pectoris is nothing but it is the symptoms of the IHD, and it is a chest pain. Okay, and the worst scenario of the IHD is that you all know that all over the body, it is the function of the heart is to continuously pumping the oxygenated blood and receive the deoxygenated blood. So all our vital organs and non-vital organs receives the blood supplied because of the pumping action of the heart. Okay, and if and the heart is functioning because the heart is getting blood from the coronary vessels. Now if these coronary vessels is completely blocked, then there is a total blockage of the blood supply to that particular part of the heart, and that part will be died, and that is known as an infarction. It means the necrosis of that part, and that is known as an myocardial infarction. Now, what are the various possibilities, or we can say that spectrum of the IHD? First and foremost, as we have seen in the previous slide, that the patient is having a chest pain because of the ischemia, that is angina. Then complete obliteration of the vessel, and it will lead to myocardial infarction. And many a times all this ischemia, then complete obliteration of the vessel, and myocardial infarction and sudden stoppage of the heart, all these sequences goes very quickly, and the direct presenting symptom is sudden cardiac death. So these are the different spectrum of the clinical outcomes of IHD. Now, very important to understand that different types of the angina, because the pharmacological intervention depends on the problem underlies in these different types of angina. There are three types. One is the stable angina, second is the vasospastic angina, and third is the unstable angina. Stable angina, as the name suggests, it means the characteristic of the anginal pain is fixed. It means that there is a no chest pain at the rest. But if you are doing some exertion, like some walking or exercise or sexual intercourse or any other exertional activity, Now these requires more blood supply to the heart, but that is not possible. And then the heart complains in terms of chest pain, that is known as a stable angina. Now the question arises that why the increased oxygen demand is not fulfilled. The reason is that the coronary vessels, there is a deposition of the atheromatous plaque, and because of this, now because of the atheromatous plaque is there, the coronary vessel is narrowed down. It is not completely obliterated, but it is narrowed down, and that's why there is some amount of the blood supply is there. And that blood supply is sufficient in case of the routine demand. But if the demand increase because of this atheromatous plaque, there is a no further increase in the coronary supply, and that's why there is a pain. And that's why it is also known as the angina of effort. Okay? And again, when the exertion decreases, again the chest pain is relieved. Okay? Second is the variant angina. It is also known as a vasospastic angina, as the name suggests, vasospasm. It means that here the problem lies is the coronary vasospasm. And as the vasospasm is there, the blood supply to the heart is reduced. And because of this, even if the patient is at rest, still patient experiencing chest pain, because there is a problem there is a blockage of the coronary vessel, because I should not use the word blockage, but because of the coronary spasm, the oxygen supply is significantly hampered. And it is also known as the angina at rest, and it is also known as a Prinzmetal's angina. And now there is a third variety. Actually, this is the most dangerous. Dangerous in terms of the prognosis of these angina is poor, and the chances of occurrence or the development of the myocardial infarction is very high. You can say that this third type of the angina, that is known as the unstable angina, it is a gateway. It is a gateway of the myocardial infarction. It means that here there is a atheromatous plaque is there. Now the plaque wall is very thin, it is ruptured, and it will lead to the blockage at any branches of the coronary vessel. And when this rupture is there, the patient will experience the pain. And here, as the plaque ruptured and it blocks the coronary vessels, some particular branch of the coronary vessels, and the patient complains the pain even at rest. So here the characteristic of the pain is gradually increasing. Patient develops pain even at the rest. And if it is not treated, then it may lead to development of myocardial infarction. Okay, and that's why I am using this word. The unstable angina is a gateway of the myocardial infarction. It must be treated immediately to prevent the development of myocardial infarction. Now, you just think yourself. There are three different cases. In stable angina, which type of the drugs are required? In vasospastic angina, which type of the drugs are required? And in the unstable angina, which type of drugs are required? First and foremost, in the stable angina, the thing is that you have to correct this mismatch between the supply and the demand in the times of exertion. Now this can be possible by three measures. One is if you increase the coronary blood supply. Now how you can increase the coronary blood supply? You cannot develop new vessel. This can only be possible if you dilate the coronary vessels. So the coronary vessel dilators. Okay? And these are nitrates. And up to certain extent calcium channel blockers. Now the second thing what you can do is you can decrease the workload of the heart. So even if the blood supply to the heart is not sufficient in case of the exertion, but you have reduces the workload of the heart. Now how you can reduce the workload of the heart? If you can reduce the preload of the heart, if you can reduce the afterload of the heart, then obviously the workload of the heart will be reduced. Now how you can reduce the preload of the heart? If you will do the peripheral, especially the vasodilatation in the venous system, then the venous return to the heart is reduced, and that's why there is a reduction in the preload. So the agents that causes venodilatation will reduce the preload and it will reduce the workload of the heart. Then how to reduce the afterload? You know that the afterload, it is due to the peripheral vascular resistance of the arterial system. If you can reduce this total peripheral resistance by arteriolar dilatation, you can reduce the afterload. So the afterload can be reduced by giving the arteriolar dilator. And if you find out the agent that reduces the preload and the afterload both by causing venodilatation and arteriodilatation, then it is the best. Okay? So the three measures. One is the coronary dilator. Second is the agents that reduces the preload, it means the venodilator. Third, the agents which reduces the afterload, that is arteriodilator. And you can reduces the oxygen demand of the heart by reducing the work of the heart by decreases the heart rate, cardiac contraction. And this is possible with the help of, you know that on the heart there are the beta 1 receptors, and when these receptors are stimulated, there is an increased heart rate, increased force of contraction, increased conduction. So if you give the beta blocker, all these will be reduced up to a considerable extent, which will reduces the oxygen demand of the heart. Because dear friends, understand this very carefully, that all organs of our body gets the blood supply during the systole, but only the heart receives the blood supply during diastole. And when the heart rate increases, okay, normal heart rate is around 72 beats per minute, but when it increases to 80, 100, it is at the cost of the diastole. So whenever there is a tachycardia, the diastole is reduced. And because of this, the blood supply to the heart, the duration during which the heart gets the blood supply reduces. So if you are reducing the heart rate, you are actually not prolonging, but you are preventing the reduction in the phase of the diastole. So that is actually very much helpful to increase the duration of blood supply to the heart. So in the stable angina, the drugs that are helpful are the drugs which causes coronary vasodilatation, drugs which causes reduction in the preload, drugs which causes reduction in the afterload, drugs which causes decreased force of the contraction, decreased heart rate. Now the second case, variant angina. Variant angina, what is the problem? Here the problem is the coronary vasospasm. The problem is not of the demand, the problem is of the supply. So here you just think that even if you are giving an agent which reduces the preload or reduces the afterload, or even if you reduces the cardiac functioning by decreasing the heart rate or force of contraction, your problem is not solved, because the problem is not of demand. Here the problem is of supply, and that's why the agents that are required are the vasodilator agents. So, which agent is not useful? That is actually very useful in the stable angina, that is beta blocker. Why beta blockers are not useful in the vasospastic angina? One thing is that the problem in the supply, not in the demand, and the second, that the beta receptors, we are just focusing on the beta 1. But I have told you many times that even if you are telling that it is a cardioselective beta blocker, but the selectivity is relative, it is not absolute. It means that there is a significant blockage of the beta 1, but you cannot say that there is a no blockage of beta 2 receptor, and this is the biggest catch. Because whenever you are giving beta blockers, some amount of the beta 2 blockage is there, and the beta 2 receptors are present on the coronary vessels. And the function of the beta 2 stimulation is coronary vasodilatation. It means that whenever you are giving beta blocker, there is a some amount of the coronary constriction. In the normal individual, it can be afforded. But in the person having already vasospasm, and because of this there is an angina, and you are giving the beta blocker, and it will lead to further coronary vasospasm, then there can be a disastrous outcome. And that's why the beta blockers are absolutely contraindicated in vasospastic angina. Now the third case is the unstable angina. As I told you that it is the gateway. It is the gateway of the myocardial infarction, and that's why your aim is to prevent the development of the myocardial infarction. And here the measures that required are, if you can give the coronary vasodilator, very good. If you can reduce the workload of the heart by reducing the preload and the afterload, very good. If you can reduce the workload of the heart by decreasing the force of the contraction and heart rate, very good. But additionally, there is a requirement of, here you know that when the plaque is ruptured, it is a dangerous because there is a further aggregation, platelet aggregation and thrombus formation and the cascade of events. So additionally, there is a requirement of antiplatelet agents, hypolipidemic agents, anticoagulant agents. Okay? So, these are always prepare the topic like this, the what is the problem and how you can solve this problem, and which are the different drugs which can helpful to solve this problem. So in the pharmacotherapy of the angina, if someone asks you which are the anti-anginal agents, your answer should be, we just quickly go, the agents that the nitrates, okay, these are used, then the beta blockers, cardioselective beta blockers, then calcium channel blockers, then potassium channel openers and antiplatelet agents. These all agents are useful in the angina. Now how these agents are useful, that we will discuss in our next class.